We're going to start off with someone who probably needs no introduction to the bank. You would have seen him here, Peter Wharton-Hood. He's well familiar. He was the Deputy Chief Executive of Standard Bank, and he's now the Chief Executive of Life Healthcare Group. So it's great to have Pete in the room. Pete, in his position as CEO of Life Healthcare, recently, as early as January this year, led a delegation from Life Healthcare presenting to Parliament on Life Healthcare's thoughts around NHI and how it could work and some of the challenges. And really that's why I asked Pete to join us today. So really appreciate you taking the time and looking forward to the debate. So please come up, Pete. As a starting point, just give us a sense as to how you look at NHI and the concept around it, just as we shape the discussion of what it is, because a lot of people actually don't really know what is being proposed.
Universal health care coverage, as a philosophy, you can't argue with. And I think ideologically, our government has taken a stance that healthcare and education needs to be delivered by the state, and doesn't really see the private sector as being the key contributor to that outcome. So when one thinks about what the government's really trying to achieve is ubiquitous access to quality care for every citizen in this country. The challenge that NHI is really trying to solve is not just, is the philosophy right or wrong? It's how do you actually get it done? If you want to improve the service delivery of healthcare in South Africa, is it more money? Or do we have to relook at the processes? And our take on it as a company was not dispute the philosophy, but get to the pinch points of what's really going wrong. And in that context, this country is short 21,000 nurses, it's short 13,000 doctors, and it is horribly short of competent hospital managers. Money doesn't solve that problem overnight. So when one gets to the context of what really needs to happen, it's more about the practical issues and less about the debate about a single payer and how we're going to actually fund the shortfall in healthcare spending. And that's where we want to take the debate.
Obviously, you led the delegation from a Life Healthcare perspective that presented to Parliament early Jan. Realistically speaking, where are we in the process and how do you see it playing out, from here?
Well, it seems, to my mind, the read on the situation is they're trying to rush it through from a legislative perspective. So the paperwork and the procession of legislation required to enable this seems to be the priority. And we've said you can't build a house on sand. You have to get the building blocks right if this is going to be sustainable and it is going to work. So we would far prefer to see a milestones-based approach where we get the basics right. And as the basics get delivered back into the system, so we can then get to more complex arrangements around sources of funding, the single or multiple payer debate, and the access to more complex healthcare. Because we mustn't forget the primary objective here is in primary healthcare. Neonatal and maternal care is where the real demand in the system actually is, as opposed to thinking about complex surgery, knee replacements, and complex medical cases. The demand is far more at the lower levels, and that requires a solid foundation with capable and competent executives to run processes and sufficient resources to be able to do it. Nurses, doctors, hospital managers. So what we would rather see is an acknowledgement of where the deficit actually sits, as opposed to the theoretical argument of how to enable the legislation, and then to put the building blocks in place so we all work together to actually raise the overall quality of both the infrastructure and the resources available in the country.
Isn't there, and maybe what a lot of the people in this room are here for today is, there's a concern that NHI actually accelerates the deterioration of healthcare in this country. Is that a real concern, or is that a narrow perception of the few that have access to those world-class services that exist in this country?
And I think the bastions of society don't want to see a compromise to any clinical outcomes. Improving access and affordability does not mean deteriorating clinical quality. Otherwise, the do no harm maxim that doctors and nurses subscribe to doesn't work. NHI will not compromise the clinical outcomes with people who have access to the care. It will improve the clinical outcomes for those who have no access at the moment, and there will be a two-tier market. like there is in the NHS in the UK.
If you look at COVID and running a business through the pandemic, working alongside government to deliver a national solution to a global crisis, if anything, that would give a real window into how this could play out.
COVID went through the system in pockets.
Yep.
It didn't hit the whole country in a sort of in a one-size-fits-all way. And we devolved decision-making in COVID to the hospital managers. We decentralized all the key decisions, and that's where the cooperation with government then started to play out. Because what people forget is the government's healthcare delivery mechanism is not run from the center. It's run by province. So you can't go and do a deal with the Department of Health. You've got to go to KZN, you've got to go to the Western Cape, you've got to go to the Eastern Cape. So we had to do bilateral agreements with the government to actually say, COVID patients that can't be accommodated in the state, we will take them into
Even though we were under state of emergency and still had to go.
We still had to go in,
okay.
and we ended up with different deals across different provinces. So when you talk about inefficiency in getting cooperation right, 9 meetings as opposed to just having one, it would have been helpful. And in that way, what we did show was we can improve the engagement. And we also showed that by working together, you ended up with much better outcomes. And we also proved that government can't do it by itself. We also can't do it by ourselves. And we just have to keep reminding people to go back to the basics to say the delivery of care across the country is far better achieved if we work together, as opposed to either have standoff or, worse still, complete ignorance as to what different people's capabilities actually are.
Look, Pete, I think we're going to leave it there. I think this is a debate, we could have for hours and hours,
Sure.
days and days. I think clearly there's a lot of water to flow still under this bridge as things shape. And we'll obviously follow it with interest and no doubt participate as best we can as a bank in the discussion. But really appreciate you taking the time out of a busy schedule to join us.
Clive, thank you very much, and for the support you've given to Life Healthcare at Standard Bank. It's great to be back here, and it really was, it's a comfortable chair.
It's a come again. Good. Thanks, Pete.
Cheers, thank you very much.